Okay, and it's a great pleasure to introduce Marco, who is also a physicist, but now a medical student. So thank you.
Yeah.
So it's the top button, and you have to hold it. Yeah, and I think it'll just come on screen in a moment. So, and Marco is going to talk about some of the work that we've been doing, looking at routine EEG monitoring during ketamine treatment. Yep, that's fine. It's fine. If you speak up, you'll be fine.
Okay, sure. Perfect. All right. Well, thanks everyone, and thanks to Rupert and everyone for organising this conference and inviting me along. So, as Rupert mentioned, I'll tell you a little bit about how we've been trying to implement EEG monitoring to see if it's even possible in our kind of routine Oxford setting. So, I don't need to introduce ketamine to this cohort, but I do want to make a couple of points to start off with. I think the first one is that whilst clinically we know that this works, we don't really have many biomarkers that could allow us to predict what's working both acutely and prognostically. And so that's part of our interest in, could EEG be part of that package? And I think the talk after me is going to touch on that as well. And along similar lines, again, we know that this drug induces acute dissociation, but we're still somewhat limited in how we describe that, with the CADs, for example, being originally described for PTSD. And so that might be important as we try and explore these questions around, does it change in the opioid effect? Is it important for therapeutic outcomes, etc.? On the EEG side, existing studies have shown that ketamine quite robustly in both patients and healthy controls decreases particularly alpha power. That's kind of what's seen in this big blue difference over here. And there might also be some effects on kind of higher frequencies, particularly the gamma power. And it might also depend which region you're looking at and whether it's kind of deep or shallow in the brain, etc. So what we were interested in is, first of all, is it even doable where in a routine, not a research setting, you get something that's reasonable in terms of the EEG side, and also exploratory look at how this relates to potentially the dissociative symptoms. So we used the Muse S headband, which is a pretty cheap validated device that you can get commercially, which has 4 EEG channels, 2 frontal and 2 temporal ones. And our study design was quite simple. The patients would be getting their effusions as they normally would in that clinical setting. And we recorded their EEG from about 5 minutes before the start of the infusion, then the usual 40-minute IV infusion, and then to about 15 minutes after the infusion as well. Plus doing some questionnaires both before and after the infusion, particularly interested in dissociation, so things like the quick version of the CADs and the 5D altered states of consciousness. Right. So in terms of what I'm presenting here, this is just a preliminary look at the data. We're still collecting, so this is going to be 18 recordings from 12 patients. Although, just worth mentioning that right now we kind of about 40 patients, and so we're still collecting more data. But in this sample, we had a relatively balanced sex split, and the range of ages was also kind of the 30s to the 60s. Doses kind of what you'd expect, 0.5 to 1, 0.7 was about the average milligrams per kilogram. Most people wearing headphones and an eye mask. So, this is my first relatively interesting point. So we looked at what people were reporting on different dissociation scales. And what we found is that we included one item which I haven't really seen too much around, which is just a very simple visual analog self-reported dissociation. So literally, I felt dissociated. Now, our advantage was that the vast majority of these people, because they're kind of existing patients, they would have had some experiences with ketamine, so they have some handle on knowing what that means to them. And so we were interested in what that correlates with. Interestingly, there was no correlation between the CADS total and that subjective self-record. What it did, however, correlate with was more the ASC disembodiment subscale. So at least in our sample, it seems that what people themselves understand by dissociation is particularly the disembodiment symptoms. So things like I'm floating, I don't feel like I'm in my body, that kind of thing. And on the EEG side, again, we were able to replicate the decrease, particularly in the alpha power. That was the one that had the largest effect size and significance, even in this quite small cohort. You can kind of see that that's the red kind of disappearing into blue. We also seem to have seen a decrease in the theta range, although probably due to artifacts coming from the muscle, we were not able to see any changes in the gamma range. Now, again, this is quite a small study, so I don't want to make huge claims just based on the EEG, but I thought it might be interesting for people to see one longitudinal case study. So we had 4 recordings from one patient who was a new starter in our clinic. And so we recorded 4 infusions out of around kind of 6 weeks period, so one weekly. And the doses were the first one 0.5 and the rest of them at 0.7 milligrams per kilogram. Interestingly, the person got kind of less anxious before each infusion, and their mood, at least on this very crude, single item, seems to have slightly improved. But again, what was interesting to me is that on the CADs, whilst the CADs total seemed to relatively match up with the change in the dose that we had, you can see 11 to 20, and then maybe kind of stabilizing, potentially some tolerance build-up, that didn't necessarily correspond to what the patient reported in terms of whether they felt dissociated and the other kind of subscales of, for example, the altered states of consciousness questionnaire. On the EEG side, again, it was quite reassuring that we were able to replicate across the same patient 4 times the similar EEG pattern. So at the top, you see the average. And again, you can see really nicely, I can point, I think I can point. There we go. You can see really nicely the red kind of resting state alpha power disappearing across particularly the temporal channels. Interestingly, this patient potentially also some theta appearing. And maybe if you squint hard enough, potentially some low gamma, although that wasn't significant at the group effect. And if we zoom into the alpha range, you can see that, again, consistently between the infusions, we see this kind of desaturation of the alpha quite rapidly. And interestingly, the level to which the alpha drops was the same between the 0.5 and 0.7, although there was a potential suggestion that at the 0.7, it kind of disappears slightly faster, even though the plateau was relatively the same. And so, to kind of all sum this up very briefly, I think the first point from our kind of very quick look at the data is that it seems to me that how we measure dissociation matters, and I'm not the only one making this argument. There's been several arguments for developing kind of more ketamine-specific scales, and I think that potentially different subscales might reveal, for example, how it changes if you block the opioid effect, and if that's at all relevant to the clinical outcomes. In terms of the EEG effect, we were able to replicate the alpha dropout. And again, there's a discussion to be had between, for example, this cortic alpha seems to be quite easy to measure and very even, it's even on a single subject level, you can see dropping out, which is quite reassuring from a potential biomarker point of view. However, something like the deep theta is coming out as maybe more mechanistically involved in some of the dissociation, although obviously a lot harder to measure with a kind of cheap surface EEG setup. So in this sample, it does seem that EEG can integrate relatively well, similarly to, for example, how in anesthetic settings, you can see EEG being used quite routinely to measure the brain state rather than just using scores, and it could potentially give us some objective markers of the ketamine effect and look at things like tolerance build-up over time, etc. But obviously, one of the big limitations is that it's not so well known how predictive these are of the antidepressant effects. Also reference the talk after mine. For one potential way of going forward there. And our study was, of course, limited by the design in that it was unblinded and kind of across a relatively heterogeneous group. And interestingly, this kind of dry EEG setup, whilst overall we were able to get reasonably good quality data, it did struggle a little bit with, for example, different hairstyles. And we saw a significant, small but significant increase in the amount of data that we had to reject in women just because they, on average, have more hair. And we were not able to look at the gamma, which might be interesting in ketamine. Cool. And with that, I'd like to thank everyone from the Oxford Ketamine Clinic, especially my supervisors, Rupert, Katie, and Mark. And I welcome any questions that you might have.
One question, Bart. Oh, no, you've got a question here.
Thank you. Thanks for the talk. Is it possible to run the source localization via this dry EEG?
That's a good point. We were interested in this. Now, in theory, yes. So interestingly, ideally for source localization, you'd want 64, 128 electrodes or something like that. But there are papers coming out that if you choose your electrodes well, and if you're particularly interested in, say, one specific region, even low montages of 4 to 10 electrodes might be able to do that. So that's not something we did. We didn't, for example, have MRIs or anything like that to validate it with. But I think in theory, if we knew this is the, like say you were interested in, I don't know, I want to see the precuneus or temporal parts or junction or something like that, then I think we could develop even relatively low density montages that could do that, yeah.
If you scan the MRI image, maybe also check the cortex thickness of the posterior medial cortex.
Yeah, that could also be interesting.
Yeah, we just have a paper on this, and we found this specifically correlates with disembodiment.
Okay.
Yes.
Thank you.
Thank you very much. Good. Okay, thanks very much indeed, Marco.